being able to be one of the 2 co-chairs of the Trainee Grand Rounds Research Award. Susan Vogelmeyer is my partner in crime, and along with our selection committee members this year, we had the pleasure of reviewing a tremendous number of outstanding applications for this award series. For those that are not familiar with the award series, the Trainee Research Awards were developed now 6 years ago to honor the outstanding scholarly and research work that is being done in the department by our trainees through the help and support of our mentors as well. This year we have 4 recipients for the award, and we are going to hear 2 of the recipients today. So without further ado, I'm going to turn it over to our first mentor, Dr. Josh Woolley, to present our first recipient of the Research Award.
Thank you. It's my great pleasure to introduce Brian Anderson, who he received his MD at Stanford. That's okay. He got a master's in medical sociology from the London School of Economics, and he completed a psychiatry residency here at UCSF in 2018. Before residency, for several years, he conducted ethnographic research with drug-using populations in South America. He learned Portuguese and Spanish to do that. Since 2015, he joined my lab and the research track in the residency, and he has been developing a program of research around the use of psychedelic compounds. And I'll just say one thing is that he combines a unique, he's unique in combining a laser-like focus, an encyclopedic knowledge, and an ability to go between communities and speak languages, both literal and figurative, in these different communities to make all of this possible. And it really is a joy to work with him, and I'm really excited to see all that he's going to do in his career.
So thank you, Josh and Eric, for having me. And yeah, it's my pleasure to present this work that we've been doing here in the Department of Psychiatry going back 2015 is when we started putting together this study. So this is a clinical trial called Psilocybin-Assisted Group Therapy for Demoralization in Older Long-Term AIDS Survivors. So I have no financial conflicts of interest to declare regarding this study, but I do need to say that psilocybin is a Schedule I drug, so that means that it does not have a recognized medical use by the FDA in this country. We are studying demoralization. So this is not in the DSM. It's in the ICD-10, and it is a syndrome of poor coping and a loss of meaning and purpose while feeling some sense of helplessness or hopelessness. This is a sort of a transdiagnostic syndrome of distress that we're looking at because it captures some things that some of our DSM diagnoses don't. In particular, I'm interested in existential distress, and mostly in palliative care patients, and so demoralization comes from that literature. It is highly associated with suicidal ideation. It's more associated with a wish for hastened death than is having a major depressive disorder. It's rather prevalent, especially in a palliative care population, and yet there's no real evidence-based treatments for demoralization specifically. Our FDA-approved medications haven't been tested or shown to affect this, and even demoralization-focused psychotherapies have only been shown to maybe be effective against waitlist controls, but they don't have robust data supporting their use. We're studying this in older long-term AIDS survivors, so I want to break that down a little bit. When people who are diagnosed with HIV/AIDS before the clinical availability of combination antiretroviral therapies, we're often told you have maybe months, maybe a couple years to live. This cohort of people suffered a lot of loss. A lot of them who have lived to today have quite a bit of isolation, complicated grief. And when we started to engage with members of the community and stakeholders here in San Francisco, both clinicians and patients themselves, they identified having this sort of atypical trauma syndrome. It wasn't quite meeting criteria for current PTSD, but they would say that they were, go to care providers and not really be able to address this concern that they had that revolved around a sort of sense of meaningless and hopelessness and feeling like they just didn't know what to do with life when they didn't expect to live this long, and now it's been decades since they actually thought that they were going to die. In this population, older is a technical term meaning over than 50, because people living with HIV, once they get to the age of 50, start to show signs of geriatric symptoms and syndromes, and so you see a complicated medical picture in this population at a younger age as well. There's some data coming out of San Francisco looking specifically at the mental health needs of older people living with HIV. This is data from Meredith Green and her group at the General, showing high rates of depression, anxiety, trauma symptoms, as well as loneliness and low social support. This data gathered from clinics at Parnassus and San Francisco General, where they treat older people living with HIV in primary care, not mental health care. And so what did we do? We wanted to study this natural product, psilocybin, that is found in a number of different types of mushrooms from around the world. And back in the 1940s, 50s, and 60s was available as an investigational pharmaceutical product that was tested in a variety of populations. It was never actually went through rigorous clinical testing. It mostly was sort of used experimentally, and not even with an FDA IND, as wasn't really required at that time. So the data is not as good as what we might have from trials today. Psilocybin is a serotonin 2A receptor agonist, and when taken at a moderate to high dose, like happened in this study, it causes an experience that lasts for about 5 to 6 hours, where participants or patients will have a drastic change in their emotions, how they're thinking. Their behavior can be rather different from usual, and it can be described as almost like having a very vivid dream while awake. Patients report having sometimes an intense emotional catharsis, having vivid visual recollections of events from earlier in their life, including from childhood, as well as the sort of more stereotypic eyes opened visual illusions and other sensory changes. Psilocybin has been studied over the last 20 years in more rigorous clinical trials, including in patients with a life-threatening diagnosis of some form of cancer, who also had depression, anxiety, or some form of distress. In the largest and most robust clinical trial to date out of Johns Hopkins, published in 2016, 51 patients with a DSM diagnosis of a depressive disorder or an anxiety disorder, who also had a cancer diagnosis, were given psilocybin and psychotherapy. The two arms of the study to which the patients were randomized were either high-dose psilocybin first or low-dose psilocybin, and then there was a crossover. What you see here with the red line were the participants who had the high dose first, or the full therapeutic dose. And you see a drastic reduction in their HAM-D, or a clinician-administered scale for depressive symptoms. The participants who had, in the blue line, the low dose of psilocybin, so low that it's technically negligible, they shouldn't be able to notice effects of the psilocybin, but they can be told, you are receiving psilocybin, just at some dose. They also had a reduction in their depressive symptoms. Now remember, I said they got psychotherapy plus the drug. At this point, they probably had about 12 hours of psychotherapy, so you would expect maybe some type of response, but the effect is much greater when you get the full dose of the drug. And then you see after the crossover in this study that the low-dose first group, who then later gets the full dose, their depressive symptoms also respond, and this effect persists for up to 6 months. Now, we don't have a lot of treatments in psychiatry that when you give a drug once, we see a change from baseline symptoms to endpoint symptoms that last for months, let alone weeks. What's interesting about this therapy for me is that a lot of reports of the participants who go through these studies is that they feel connected to others around them. They feel like it's easier to open up and engage with family members. They self-disclose more in therapy. This is all anecdotal. And this is being tested in individual psychotherapy paradigms. So one participant, 1 or 2 therapists. This is a photo here of a psilocybin treatment day from Johns Hopkins where, and it's not always sitting so close to the participant, but there will be 2 clinicians in the room, mostly not talking to them, definitely not touching them for most of the day. The participant is told to lie down, close your eyes, listen to music, and then check in with us when you need to, and this goes on for about 5 or 6 hours. But this is always with one participant engaging with their clinician in this individual model. And when we're giving a drug that participants are anecdotally saying it makes me feel connecting and wanting to connect to others, it makes me wonder, why is this not studied in groups? And so that's what we did. We designed a phase 1 clinical trial that was single arm, open label, so everyone was told you will receive psilocybin. There's no placebo. And we did this to test the safety and feasibility of one, administering psilocybin with adjunctive group therapy, as well as studying this in a novel population, the older long-term survivors who have demoralization. Our primary clinical endpoint was looking at change in demoralization on a structured, validated scale from baseline to endpoint, but we also looked at other secondary outcomes like depression. As I said, we worked with long-term AIDS survivors. In this study so far, we've only worked with gay-identified men in order to create more homogeneous groups of people with similar experiences. And we selected for people who are moderate to severe on the Demoralization 2 scale. We did have to go through a number of exclusion criteria, so people could not be on most psychotropic medications on a regular basis. No psychiatric instability, meaning people with active suicidal ideation with intent, recent hospitalizations. We had to screen out people with psychotic and bipolar disorders, as well as major medical conditions like cardiac disease, and then did extensive testing on the enrollment day. Also, to design this study, we didn't just look to the literature, but we looked to the community that we were working with. So we paired up with stakeholders at the San Francisco AIDS Foundation who run support groups for older people living with HIV. We actually convened a town hall a few doors down where we presented this study, as well as other researchers presenting research that they're doing with older people living with HIV in San Francisco. We got feedback from the community on what we were planning to do. We've also presented this to the Community Advisory Board of the AIDS Clinical Trials Group at San Francisco General. And so getting feedback from not just other clinicians who work with people with HIV, but the participants themselves was very key to what we set up. The study was involved. It took about 2 months for someone to go through the treatment. They started with their enrollment, then they come in for a baseline session where they meet the group therapists, but not the other group members. Then they go through 4 group therapy sessions over about 2 weeks. The group then gets split up, and then individually, participants would come in and have their psilocybin treatment. This is a photo of one of the rooms at Langley Porter that we set up for this. The participant would sit there for about 7 to 8 hours would be the whole day with 2 clinicians in the room, just like the other studies. And then they would come back, and the follow-up psychotherapy, again, would be in a group, this time 6 sessions over 3 weeks. So then we get our endpoint assessment about 3 to 4 weeks after they've had the drug exposure. And we followed them for safety and clinical change over the next 3 months. Psychotherapy was based off of supportive expressive group therapy. This is a manualized group therapy for palliative care patients, developed out of Stanford, originally for metastatic breast cancer patients. And it very much focuses on sort of here and now, follow the affect group process, but has a real focus on expressing emotion and patients connecting with one another. Now, some of the results. Our patients were on average about 60 years old. The mean year of diagnosis with HIV was 1988, with a range of 1981 to 1996 by self-report. We did ask them, how many people in your lifetime close to you have died? And the mean average was about 26, with a range of 2 to 100, with participants saying 2 because I didn't let anyone near me and I tried to stay away from everyone to protect myself, and 100 for a participant who was a nurse in the military working on AIDS units, who himself was diagnosed in 1983. We also asked about prior psychedelic use. So this is not a psychedelic naive population. On average, about 30 times in a lifetime, ranging from 0 to 200 by self-report, but about half of our participants have used psychedelics less than 10 times in their life. And it's been, on average, 16 years since last use. We had to screen 91 participants over the phone, 30 in person, and then we were able to enroll 18. All 18 were administered the drug and completed the follow-up. And we had a 95% attendance rating at the group therapy, which tells you this is a highly motivated cohort. Only about half of our participants actually met a DSM diagnosis for the ones that we looked for. So major depression, generalized anxiety, 3 of our participants met criteria for borderline personality disorder, and we didn't do a CAPS to assess for PTSD, but they did a self-report PCL, and 3 of them had scores high enough to suggest likely current PTSD. But again, half of them didn't meet any DSM diagnosis from the ones that we looked at. Just briefly, this is a safety study, so we assessed adverse events rather rigorously. We used a grading chart from the NIH for how to classify events. We always wanted to see, was this expected, was it related, and was it serious? This is sort of the standard way to look for safety outcomes. And we had to engage with not just the Data Safety Monitoring Board here, but the IRB, the FDA, and the Department of Justice in California, because we were giving a Schedule I drug to participants. Now, the serious adverse events. These are adverse events that lead to things like death, hospitalization, some sort of urgent treatment, or otherwise cause some form of serious morbidity. We had 0 serious adverse events in the trial that were related to the study drug. However, we did have adverse events during and after the trial in this population. During the trial, we had 1 participant who was diagnosed with recurrent metastatic cancer, and that person also developed a pneumothorax. After the study, we had 1 stimulant-induced psychosis that led to a suicide attempt, and another participant had cholecystitis with an emergent cholecystectomy. We determined that these were unrelated to the study drug. The stimulant-induced psychosis, we did not screen out for substance use. We had a number of people with recent substance use, and several of them had heavy methamphetamine use in the past. So this is a participant who 2 months after the study relapsed on methamphetamine due to some life circumstances, and then made a suicide attempt during his brief psychotic episode. There was also no change in suicidality over the study, and we assess this at every study visit per FDA mandate. Now, specifically looking at safety events on the medication treatment day, there was a fair bit of anxiety that met criteria for being moderate or severe. There was some paranoia, and 1 participant did develop thought disorder briefly during the day that self-resolved. And there were medical events as well. So we had hypertension in almost all of our participants. The participants who met criteria for severe hypertension, they all had a diagnosis of a current anxiety disorder at baseline, and we know that people who have anxiety are also more likely to get more anxious. The hypertension would resolve when we would talk to them and they would calm down. And other medical changes happened on the day as well. We also looked at medical events after the psilocybin while they were still in the study. Several people get a headache. This is common with psilocybin. There was 1 person who had an anxiety exacerbation, and that also led to a methamphetamine relapse. This is a separate participant. And we found that was unrelated to drug exposure itself, most likely. And then there was 1 person who had what I'm calling a post-traumatic stress flashback. So this person did not have current PTSD, but had traumas in their life. They did not have this flashback on the medication day itself, but 2 days later, they had a very vivid recollection of having been sexually assaulted years prior. And it seems like maybe the psilocybin sort of primed them to have this. What's interesting is that this participant, years before the trial, also had a very similar vivid recollection of their sexual assault after starting efavirenz, which is a antiretroviral drug that is a known serotonin 2A agonist. So something about the 2A receptor system is important in these sort of vivid recollections of trauma. Our blood pressure on the day did elevate. Like we said, at some points it was severe, but on average it raised about 20 points systolic and about 20 points diastolic, and then came down eventually. We also asked about challenging experiences using a questionnaire from Johns Hopkins designed to look at psilocybin experiences. This questionnaire asks about experiences of fear, fear of insanity, fear that you're dying, and you'll see that, so higher scores in the blue lines are people who had more fear or challenging experiences on the day. Anything above maybe like a 50 or 60 is probably clinically significant. And if you look at the orange bars, you can see we asked them this questionnaire at the end of the study. Did you think being in the study was beneficial? Did you think it was harmful for your mental health? The participants who had challenging experiences did not report that the study was more harmful for them. They actually still reported it was beneficial. And this is our clinical outcomes. So just to break down the scale a little bit, this tracks self-report demoralization over time. If you look on the far left, so we screen them over the phone for demoralization. They come in for their enrollment visit, and this is their baseline session before any psychotherapy. You notice there's not too much of a change, but there is a little bit of improvement. After 4 sessions of psychotherapy, the demoralization has not changed on average all that much. Then they take a break. Everyone gets their drug treatment, and the next time we measure demoralization, about a week or 2 after the drug, it's changed quite a bit, and then persists at a lower level over the next several weeks to the 3-month follow-up. The gray lines in the background are the individual trajectories of our 18 participants, and the black is just our average. And in case you want to see a condition that's a little bit more familiar to us, we also use the SESD, a self-report screener for depression that's commonly used in studies with people living with HIV, and we see a similar response, not quite as large, but and again, this is a population that didn't meet MDD criteria on average, but had some major depressive symptoms. We see that they do actually get a little bit better just with the psychotherapy. They continue to get better with the medication, and then that persists at a lower level moving forward. Okay. So that's my timer. So I'm going to conclude that we were able to show that this type of drug-assisted psychotherapy is feasible and how we set it up. It can be safe in this population with the many safety controls that we put into place. And we were able to show large effect sizes on demoralization, depression, and some other self-report measures. But again, this is an open label study, so there's no placebo control. Everyone knows they're getting the drug. This study is not very generalizable to other populations. Long-term AIDS survivors are a very unique patient cohort. And we used our primary inclusion criteria of demoralization, which is not that well known in psychiatry, though it is more well known, for instance, in psycho-oncology. And certainly we enrolled participants who wanted to be in the study, who were looking for something and were amenable to psilocybin therapy. So we're going to have some bias there with that population. Next steps are we're opening up the trial to work with groups of women this year. We have that approved by the IRB. In the future, we'd like to do trials that do have an active control, looking at demoralization, pain, trauma, and then we're considering doing a similar type of study with group therapy, but with a different drug, MDMA, in veterans with PTSD. Finally, I just want to thank the very large team it took to put this together. Josh Woolley, my mentor, Jenny Mitchell, also a mentor of mine, our co-Is, Chris Stauffer and Jim Dilley, and Alicia Danforth and Rob Daroff, without whom we could not have put together the clinical intervention here. On top, we have 3 of our consultants for this study who are long-term survivors and incredibly helpful in thinking through the issues of this study, and the various clinicians and people who've volunteered their time to help make this happen, including Eric Hung, our data safety monitor. I'll just conclude that this study was all funded by philanthropy, except for my time, which was covered by training grants here at UCSF. Thank you.
5 minutes for questions.
Marty.
First of all, congratulations to you and your mentor, Dr. Foley. Going forward into your career award application and methodology, are you considering considered content analysis of what they say because you've recorded therapies?
Yeah, so we have recordings of all the therapy sessions. We're actually starting to do the qualitative analysis now. Alex Trope is actually going to be looking specifically at the group therapy sessions, look at how process changes and disclosure changes in groups. And we did interviews the day after the psilocybin treatment day and 3 months later to assess patients' own perspective on their change. We also interviewed important others in their life, partners, close friends, to get their perspective on change that they can observe in the participants. Adrian.
Expectations. I know they were told you're getting psilocybin. Did they understand one would be higher, one would be lower, or those would be variables?
So the higher or lower is from a prior study. In our study, they were told you're going to get a moderate to high dose, and we tried to describe what those effects could be. And then the informed consent process, we take very seriously for the study to really try to walk through what can happen, the subjective effects, but also these various, physical effects that could happen as well. Susan.
Adverse effect of the person who kind of relapsed onto methamphetamine. I mean, so, you're saying that it is, you think, unrelated.
Mm-hmm.
But how did you arrive at that? Then maybe one can imagine and see an FDA board saying, well, you've given them the idea that it's okay to do these kinds of drugs or something, and so
Sure.
then they did it.
So this particular person, once we heard about this relapse, we did an interview with them, and their story was that they're about 50 years old. They had been using substances going back to being a teenager, had been a regular methamphetamine user in the past, and actually was still using psilocybin mushrooms about maybe once a year on their own prior to the study. They relapsed on methamphetamine and said that they hadn't used speed for quite some time, and they did it in the particular context of someone very close to them died and they felt horrible and they just wanted to feel better like they used to, and that and then they had this brief psychotic episode, which they had actually had 1 years prior to methamphetamine as well. So that helped us understand that they were sort of prone to that. It wasn't necessarily the psilocybin making them maybe more susceptible to having a psychotic response to a stimulant, which is also possible. The fact that it happened 2 months after their psilocybin treatment day, and the fact that I saw notes from the person's primary care provider saying that they've been doing really well since the study, depression was better, anxiety was better, and was functionally doing well, made me think that this was sort of a new event and not a continuation of the psilocybin effects. Jen?
I'm just curious about the subjective report of the participants, particularly the ones who had taken psilocybin on their own in the past. Is there an added benefit to this kind of structure provision of the psilocybin?
Yeah, so I feel like a lot of what made this study go well and avoid more adverse events is that we created a real sort of container and a setting of like a feeling of safety where they were able to trust, at least if not us, the other group members. There was a significant amount of paranoia among some of the participants towards doctors in general, towards the healthcare establishment that maybe had failed them in the 80s and 90s, but they were really able to sort of trust the other group members. So we worked on that, building that trust. And then the other thing, sorry, your question was? Oh. So this dose is high. Even participants with a lot of experience with psychedelics said this was a challenging experience and sort of an intense experience. A number of them said they were happy to do it in this medical setting. They're older, maybe they have more health issues, or it was just such a high dose that to do that on their own would have been overwhelming. And then one participant actually who is now in sobriety for 20 years said that he only wanted to do this in a medical setting when it was doctor recommended and he wanted help for some trauma and grief and things going on in his life, but he didn't want to go do it on his own because he thought that would be a relapse. So he felt safer doing it with us, and then we also got feedback from one of his close care providers that they sort of were okay with him doing it in the setting. They didn't see it as a relapse. So there's something about this clinical context which may be help with people feeling comfortable and feeling like this is a safe way to do this. Yeah.
What was there that
So we try not to guide people's experience. There's music that we selected. We spent a lot of time sort of making this playlist of songs that we thought would be evocative and sort of fit the right times of the drug experience itself, but the clinicians were mostly being silent. We're actually sitting several feet away, and we try to untrain clinical interventions in our clinicians. You know, we have some of the clinicians here in the audience who could speak to this, who know that instead of offering an interpretation, instead of offering a confrontation, you more just try to sort of witness what they're saying. We take notes, and maybe at the end of the day, we'll bring up some themes that they were spontaneously saying, but we really sort of go into the interpretations and working with them the next day at a 2-hour therapy session that we do. So we try to do very little on the day itself, as long as they're safe and calm enough in the room.